I'm going to ask all the panelists to come up. We got about 10 minutes for questions, and we'll fire through these pretty quick. You can also get to the microphones, but we're going to start with the online text questions. Dr. Applegren,
I am
since
online.
you're ready.
I'm ready.
Shoot.
Keith Applegren from Pittsburgh. One of your options, Jeff, was expectant management. And I've had patients that have had one small stone, and on post-op ERCP, it was normal. So my question is, in what situation would you do expectant management and just wait?
Yeah, there is a rate of clinically insignificant common bile duct stones. What that rate is, I do not know. I would say a stone less than 3 to 4 millimeters in an asymptomatic patient who never had any previous symptoms of a common bile duct stone, never had an episode of pancreatitis, has normal liver function tests, has small stones in the gallbladder at the time of cholecystectomy. That patient has probably been passing stones the entire time and leave well enough alone. Any other comments?
Rick Kazarek and Bill Traverso showed that stones were identified on cholangiograms sometimes up to 2 to 3 millimeters in diameter in a study from the 90s, and those people really had no consequence from that. So I think there is some data supporting, that.
All right, I'm gonna work from the bottom up here, and this is gonna be for the panel. John, are there any gastroenterologists doing EUS immediately followed by ERCP if a stone is identified?
I'm sorry, what's the question?
Are any gastroenterologists doing EUS immediately followed by ERCP if a stone is identified?
Actually, yeah, there are, and actually the future of advanced endoscopy training for gastroenterologists really does focus on EUS and ERCP training. So most gastroenterologists are trained in both, and there is data out there showing it is effective and probably more effective and probably more safe for the patient to do EUS in the fluoroscopy room and be ready to do ERCP at the same time. So yeah, the answer to the question is yes, it's being done frequently.
Okay, this one will be for Ray. If Marizzi syndrome is suspected, why waste cost and time with EUS when cholecystectomy is what is needed? Stone in the gallbladder neck causing common hepatic duct compression can be seen on CT or ultrasound.
Because it's really cool. Did you see that? Did you see the EUS there? Did you not see that? Wasn't that really cool? Actually, no, the answer was there was, this patient had actually had some weight loss. They were actually concerned that there might be a malignancy in there. They saw the stones, but they thought there might be an obstructing mass, so that's why we did it and got that really cool video. So
I'll leave this one to the entire panel. And this, I apologize, the computer does cut off some of the questions, so we won't get some of the full question. If you hear your question and you want me to finish it, get up to the mic and let me know. How can we better educate our ER medical colleagues to prevent the full $1 million workup, unquote, on, just hold on every patient, ultrasound, HIDA, MRCP, CT, et cetera?
I can start with that. Let them know that you can clear the common duct. Like we showed on one of my first slides, when surgeons were able to clear the common duct 90% of the time, the people in the ER didn't have to go through $1 million workup. But nowadays, what they see is a general surgical population that is incapable of clearing the common duct without a number of interventions. So we have to learn how to do common duct explorations, or they're going to keep doing $1 million workups. And the caveat to all that is that if it costs more to do an ERCP and sphincterotomy and clear the stones, and if the companies are already not paying us much for common duct exploration, where are they going to get the money? They're going to take it out of lap chole. So you're going to be doing a lap chole for 50% as much reimbursement as you're doing it now to pay for all the extra expense, in addition to which you're going to have a hospital nurse or manager telling you what you can and can't use and what's going to be on the shelf.
Medicare pays $30 less for doing an IOC with a lap chole and $100 less for doing an IOC with open chole. Comments? I wasn't aware of that personally. Is anybody else aware of that?
I know historically, if you add a common bile duct exploration to lap chole with intraoperative cholangiogram, there was only a reimbursement increase of $50. Last year that changed. So actually you get reimbursed more. I think part of that, as we all know, is that lap choles are poorly reimbursed to begin with because every general surgeon lied and said they could do it in 15 minutes when we can't do any procedure in 15 minutes. So we have to live with that forever. Nothing is going to change on reimbursements.
Dr. Martinez, why not start with a lap choline reserve ERCP for those patients in whom the surgeon can't clear the duct? Wouldn't that result in the rest is blank?
So lap chole instead of preoperative ERCP, that puts a number of issues together, as we had mentioned. That is my preferred route in a patient that's not highly suspicious. If the patient is highly suspicious, in the setting where the surgeon is not going to have the skill set to do the common bile duct exploration. Remember, a lot of the ERCPs I am doing, I'm the consultant. I'm like the gastroenterologist or the surgical endoscopist. So these patients are being managed by somebody else. The lap chole is going to be done by somebody else. And in these high settings, the ideal is to clear it preoperatively to eliminate any postoperative issues. But again, a lot of to what the data says. These has to be highly suspicious for stones or have already been seen. But I would also then venture to say that the IOC should be being done more often to minimize the need for diagnostic ERCPs. And I also, the algorithm should be really clear to eliminate that extensive workup. Patients with stone disease, all they need is an ultrasound and laboratory work, and that's it. And IOC done in the operating room, and then post-operative ERCP if something is found. Intraoperative management of the stones is great, but we got to then perfect the teaching capabilities of making these patients, making the surgeons being able to do the procedure.
Dr. Hungus.
Jeff, this was a great session. This is more just of a comment and a shameless plug for the Learning Center. So we have a laparoscopic common bile duct simulator down in the Learning Center, and based on a mastery level curriculum that we've put together. And I think that we're going to have to address this somewhat, some of the training issues with simulation to at least potentially try to get our residents through their learning curve faster, or even more junior faculty who haven't done many of these. And I just want to get your comments on that, and then again, just shamelessly plug the Learning Center.
I think it's a great idea, and I would advise everybody to go by the Learning Center and check out this, the simulators. When we don't have faculty that can teach a common duct exploration, if the faculty is doing less than one a year, how are they going to teach a resident to do it? So I hope people do come and visit your station.
Okay, in the interest of time, this will be the last question in the back.
Sure. Dave Shears, Grand Rapids, Michigan. I have to certainly support everything Dr. Bursey, and you talked about trying to increase training of the laparoscopic common duct exploration. It seems most of the people able to do that are actually the senior surgeons that learned it during the era of open cholecystectomy when that was done. Certainly if the junior people cannot pick it up by simulation, we almost may have to leave this to the intervention radiologists that actually have a very good success rate, even though it hurts a lot more. Yes.
Any other questions from the audience? Otherwise, thank you very much for coming, and enjoy the rest of the SAGES meeting.
Thanks. It was a nice session.